before, which actually made my life easier in making this presentation, because we discussed all the problems, and I will present you a different way of dealing with these problems, which were mentioned before. As we all know, and as was said before, the problems of hardware fixation, implant failure, especially in osteoporosis, and this makes 65% of the cases. Also, the morbidity in all patients, which are more than 60% of the cases, the patient don't want to go to the hospital, they don't want to have open surgery. Besides the complications of open internal fixation and reduction, as we know, there's infection and avascular necrosis. A study was presented in 2009 trying to avoid these complications by suturing the fragments together with open reduction and suture fixation by Dimakopoulos. And so this was applicable, especially in cases of osteoporosis, and lessen the damage to the blood supply to the head through the hardware. This technique has stimulated us to try to do that arthroscopically and have even better avoiding of the vascular disturbance from the open surgery, beside avoiding the hardware complications. We started doing this techniques in 2011, and with time we have improved it several times. I will describe this technique. Actually, the patient is a sitting position with the arm hanging, and we use 4 portals, 2 posterior and 2 anterior in most of the cases. Sometimes we use even more portals. Instruments we use, we do 3 instrument sets, the giant needle instrument sets, and they're called the penetrating suture wire. It is a wire with a hand grip from its end, and the suture is in the front end or the proximal end. And this wire is used to pass suture through the bones, and the passing pin, which is also used in the ACL surgery. Another instrument actually which we use very much is the choke needle. It's by pulling the suture through the skin without the need of a portal from anywhere through the shoulder, and give us much more mobility and less time. Now, the reduction in K-wire fixation was presented very nicely before from Dr. Eid. And we do the first close reduction and fixation with K-wires under the vision of the arthroscope. And the reduction is then made, and then we start suturing of the fragments. We have 4 techniques. One is the vertical giant needle technique. It's mainly used for 2 parts tuberosity, greater tuberosity fracture, especially when it is displaced superiorly. The horizontal passing pin technique is for 2 and 3 parts. Also for the greater tuberosity, if it was displaced more posteriorly, medially, blocking the external rotation. And the mattress giant needle technique, if we have the 2 tuberosity fracture, in case of 2 to 4 fractures, 4 parts fracture, it is by suturing the 2 tuberosities together through the tendons. And finally, the vertical PS wire or penetrating suture wire technique by fixing the head to the shaft, especially in surgical neck fractures. Now, the vertical giant needle technique is, as I said, we pull the fragment to reduce it in its place using a hook, and then fix it with K-wires under scope vision. and then we pass the suture with the giant needle medial to the fracture and pull the two ends through the instrumentation portal, and then suture the fragment in its place. We see we go through the about 1 centimeter medial to the fracture, and then put the suture, and then this is the chop needle puller to pull the fragment, to pull the suture through the instrumentation portal and suturing it. Now, the horizontal passing pin is a transosseous suture fixation. As I said, it's for this especially greater tuberosity posterior displacement. We pull the tuberosity with a hook to its place, and then fix it with K-wires, and then we pass the pin from anterior medial to the sulcus, to the biceps sulcus, and then pass the suture through the head, and then fix the fragment in its place, and then pull the fixing wires out. We see we are pulling the fragment with the hook from posterior to anterior, fixing the K-wire, and then we go with the passing pin and pass the suture from anterior to posterior, and then pull it out through portals and get the suture. Now, the mattress giant needle fixation is a transtendinous tuberosities fixation. We put the suture through the infraspinatus tendon and the other suture through the subscapularis, then pull the lower two ends outside the instrumentation portal and tie them together, and then pull the suture, one end of the suture out, so that the knot will pass through the tendon out in order to have to be able to make a sliding fixation knot, which is actually very strong and stable. And then we tie the two fragments together. This is actually, especially in cases of when the cases of valgus fracture, where the tuberosity is displaced and the head is impacted, so we push up the head under scope, and then when we tie this, it automatically will come lateral to the head and fill the place, and also stabilize the head. Here we see, and the sutures passing through the two ends, and then when we tie them, the fragments come together. Now, this is the last one. The fourth technique is the vertical PS wire technique. It's a transosseous penetrating suture wire. Here, in the case of varus angulation, do abduction, then fixation with K-wires from below up through the shaft into the joint, and then we pass the PS wire. The PS wire, as I said before, the suture is in the anterior end of the wire, and then we pass it through the shaft and head inside the joint, and then we pull it, the two ends out through the instrumentation portal and tie the suture, the head to the shaft. Of course, all this is done through the K-wire fixation, and after tying the knots, then we remove the K wires. You see, this is the penetrating suture wire through the head. We pull the suture out. We can use the suture as a loop also and put the type of suture we like to put, and then pull it out and then tie the shaft to the fragment. I usually use absorbable sutures, sometimes non-absorbable. This is a case of a head valgus fracture with the head rotated, with the greater tuberosity displaced medially, causing loss of external rotation. So we did the reposition and fixation with the suture. As you see on the right side, we have corrected the angle of the greater tuberosity, and the head is placed relatively in a good position. This is the patient 6 weeks after surgery. Her external rotation is good. And this is another case of 3 parts valgus fracture. Above is before surgery, and here is after surgery. After pushing the head, we push the head with a metal finger, and And then we, as we said, we do the matrix suture and tie the tuberosities below it. And you see below how it is after the reposition. This is the patient 3 months after surgery, approximately completely normal range of motion. Here's another case of complicated four-parts valgus fracture. And we have used a spatula to push the head up and then tie the tuberosities below it. As we see here on the left, the angle of the head to the shaft is about 70 degrees, and after reposition is about 120 degrees. After surgery, we immobilize the patient 3 to 4 weeks. Then we start rehabilitation. We always tell the patient that a second surgery may be needed to release adhesions if it happened because of the long time of immobilization. But actually, in the 34 cases in this study, or 33 cases, no need was for a second surgery. The time from 2011 to 2017, these 6 years, we operated 33 cases of displayed proximal humeral fractures, all treated with reduction and arthroscopic transosseous fixation. We were able to re-examine 28 cases, 19 females, 9 males. The average age was 60 years, between 24 and 90. The follow-up average was 2.5 years, between 12 and 73 months. According to NEAR classification, all fractures were excellent. The 3 parts fracture, half of them were excellent, the other half were satisfactory. And the 4 parts fracture, 29% were excellent, and 42 were satisfactory, and 29 were unsatisfactory. We didn't have any AVN as a complication. All fractures united in 4 weeks' time, approximately 4 weeks' time. The malunion was present in 2 cases of the 4 parts fracture and 3 cases of the 3 parts fracture. Signs of impingement syndrome was present in 2 cases. So in conclusion, the clinical and radiological results encourage using the arthroscopic technique of treating proximal humeral fractures, especially in old osteoporotic patients, as an alternative to open reduction and internal fixation. Of course, many patients, especially old patients, they said, when they say, okay, I'll come and do the surgery and go back home on the same day, and it's arthroscopic surgery, they will have this option instead of the option they refuse, which is open surgery. Now, this technique is our first option in head splitting fractures and anatomical neck fractures, even in young patients. And the early results are actually promising. We don't have late results till now. Thank you very much for your attention.